name is Dr. Val Montessori, and I'm the Director of Clinical Education with the BC Centre for Excellence in HIV/AIDS, and I'm really happy to welcome you today to Chapter 4 of the BC-CfE Anniversary Conversation Series. 2022 marked 30 years since the creation of the BC-CfE, and the aim of this series is to celebrate and commemorate the journey and the accomplishments of the community, advocates, researchers, and healthcare providers that have worked to turn the tide of HIV in British Columbia. So today's session is titled HIV Prevention, BC's Pre-Exposure Prophylaxis or PrEP program, and as you can see, or you will see, we'll be joined by Drs. David Moore and Janine Toy, and really happy to have them with us today. Dr. Moore is a public health physician and research scientist at the BC Centre for Excellence. He's a professor in the Department of Medicine, the Division of Infectious Disease at the University of British Columbia, and he's been conducting health service and populations health research related to HIV and other sexually transmitted infections since 2004. So welcome. And Dr. Janine Toy is the Senior Manager of the Drug Treatment Program at the BC Centre. She's a clinical pharmacy specialist with St. Paul's Hospital Ambulatory Pharmacy and a clinical instructor for UBC faculty in pharmaceutical sciences. She has specialized in HIV care and antiretroviral therapy for 20 years. She's a member of the BC-CfE's Committee for Drug Evaluation and Therapy and co-chair of the BC-CfE's Drug Treatment Program Data Quality Committee. So welcome, Dr. Toy. So following the presentation, Drs. Moore and Toy will engage in a conversation, because it's a conversation series, about their experiences with BC's PrEP program, and they'll be able to take questions from our audience. So I'm really looking forward to that part as well. But before we start, I'd like to acknowledge with gratitude that our place of work is on the traditional, ancestral, and unceded territories of the Coast Salish Nation, the lands of the Musqueam, Squamish, and Tsleil-Waututh. And this acknowledgement is a reminder of the discriminatory, racist, and colonial practices that have had a lasting legacy and continue to create barriers for Indigenous peoples in our healthcare system. Quickly, just to review our presenter disclosures, both Drs. Moore and Toy are members of the scientific committees and neither have financial conflicts of interest. And as far as mitigating potential bias, the content of the presentation has been developed by the speakers, and where relevant, both positive and negative trials will be mentioned. Generic names of medications are used in place of brand names. And quickly, finally, before we get to the actual presentation, we'll just review the learning objectives. We will review the evidence for the efficacy of pre-exposure prophylaxis in terms of preventing HIV infections in key populations at risk for acquiring HIV, describe the development of clinical guidelines for the use of HIV PrEP in BC, review implementation and client participation in the BC PrEP program, describe some of the early impact of HIV PrEP among gay, bisexual, and other men who have sex with men in BC, and finally, overview safety monitoring in the BC PrEP program. So with that, I will figuratively and actually pass things over to Dr. Moore.
As Val mentioned, I had a role at the CFE on the Therapeutic Guidelines Committee, but also, I'm a co-principal investigator on the Momentum 1 and Momentum 2 or Engage studies, which generated a lot of data to support the development of the program, and now we're actually in the process of helping to evaluate it. So this randomized trials of PrEP using entericidamine tenofovir have been very supportive, largely with men who have sex with men. So all of the studies listed here, IPREX, IPREX-OLE, PROUD, and IPREA, demonstrated a clear efficacy of PrEP in preventing HIV infection in high risk, or men who have sex with men who are at high risk of acquiring HIV. For heterosexual couples, all the studies listed here were really amongst HIV serodiscordant couples, predominantly in sub-Saharan Africa. And the results of those trials were somewhat mixed. Some of the studies, like the Partner PrEP program, showed a clear benefit to providing PrEP, but most of the others did not. And then lastly, there's been only one randomized clinical trial looking at pre-exposure prophylaxis amongst people who use injection drugs, and that's the Bangkok IDU study. For that, it was, did show some benefit to providing PrEP in that context, but the issue there was, basically the challenge is that they had to run this study for a very long time in order to get sufficient number of new infections in order to analyze, largely because once you enroll people use drugs in a study or in a program and provide them with, best available preventive care, which is clean needles and syringes, the risk of acquiring HIV really becomes very minimal. So different sort of challenge in that population. So amongst the three main randomized trials of HIV PrEP in men who have sex with men, the first one was the PrEP study, which was published in 2010. And overall, it found an efficacy of, or a risk reduction of 44%, which was a little bit disappointing. People had hoped that something, along the lines of 50, 60, 70% would be shown. But really what became clear is that adherence was a big issue in this study. And amongst those who they could actually detect drug levels of tenofovir in their blood, the efficacy of PrEP was actually 92%. So clearly worked, but we needed to do some convincing of study participants and potentially clients that this was really a valuable thing to take every day. The other two studies that occurred later after PrEP, where we had some indication that PrEP was actually effective, and where adherence, with good adherence, you could actually show some benefit, had much clearer signals of efficacy, both of them coming in at 86% risk reduction. And the other thing to point out in these studies is that they really enrolled men who have sex with men that were at high risk of acquiring HIV. So the incidence rates here, you see 3.6, 8.9, 6.6 per 100 person years. Those are really much higher than anything we've ever measured in British Columbia. And really that just kind of affects sort of the number needed to treat in terms of how many HIV infections you're going to prevent by providing PrEP to these clients. And I'll get into the incidence rates we found in Momentum a bit later. So the first guidelines that we developed for PrEP in BC were done in 2014. And of course, this was in an era where emtricitabine tenofovir for PrEP was not yet licensed in Canada, but people were, you could prescribe it off-label. And there was a lot of interest particularly in the MSM community about trying this, new and presumably effective prevention strategy, but there wasn't any really clear guidance for how we would apply this in Canada. And really our guidelines that we used at that time were really just to, largely a copy and paste from the US CDC guidelines with some slight modifications. And basically we recommended PrEP for patients at ongoing, in quotes, high risk for HIV infection, but we didn't really define that all that precisely. And it wasn't really informed by local epidemiology, but we kind of felt like, well, putting out something at that time to guide people that were interested in prescribing it for their clients was, probably a good idea. So then we revised our guidelines again in 2017. Initially, for a number of reasons, but one of the precipitating factors there was that the previous guidelines mentioned that sex work was kind of an independent criteria to be used to define high risk of HIV infection, and particularly for female sex workers, it doesn't actually seem to be a lot of evidence to support that in terms of an independent risk factor. Certainly there, for women engaged in survival sex work, where there's a lot of overlap with injection drug use, it did seem that drug use was probably the primary risk that people were being exposed to. And there was actually a publication from the VIDAS study that really demonstrated that they looked at a number of different risk factors for acquiring HIV amongst people who use injection drugs, and really sex work didn't turn out to be an independent risk factor for that. But this also suggested that we should really revisit our other criteria for defining risk in our guidelines. So we had some, we're fortunate in BC that we had good data on HIV incidence, largely coming from research studies like VIDUS and from the Momentum study. And then we also have our surveillance data, which provides us information on new HIV diagnoses in the province. We also added in some grading of evidence to help us see, well, yeah, what is actually, how good is the evidence to support these recommendations? And the other big change that predated 2017 was that emtricitabine tenofovir was licensed for PrEP in Canada in 2016. But at that time, there was really limited public funding for PrEP, and we included in our PrEP guidelines this caveat that it's important to note that these guidelines are for information purposes only and do not imply recommendations regarding provincial funding of PrEP in British Columbia, which is a bit annoying to put into a guideline, but that's what we had to do. So this is some data from the Momentum 1 study, which ran from 2012 to 2019. So in this, we're following about, say 500 or 600 HIV negative men who have sex with men who we recruited from Greater Vancouver, and we followed them up for a few years. And overall, we found that the incidence of HIV infection amongst people that were negative at enrollment was, fairly low, 1 per 100 person years. So certainly, if you compare it to those other PrEP studies, this incidence rate is low. However, you compare it to the general population, it's actually very high. But of course, risk for acquiring HIV is not evenly distributed amongst men who have sex with men, and it's pretty clear that a number of different risk behaviors, people reporting those behaviors had a much higher risk of acquiring HIV. So a lot of the usual things you'd expect, people that had a previous STI diagnosis, their incidence rate was 4.8 per 100 person years. If they reported any condomless anal sex with someone whose HIV status they didn't know, it was also up around 4.8. And so, yeah, sex work did impart this somewhat elevated risk of HIV infection, but again, these are not necessarily independent. The one thing we landed on is turning out to be quite useful was this risk scoring system called the HIV Risk Index for MSM that was developed by the US CDC. And the US CDC guidelines, they recommended that really anybody that has scores on this scale greater than or equal to 10 should be offered PrEP. And we found that actually the scoring system, which I'm going to show on the next slide, was really effective in really dividing up the MSM population into those that were at higher risk for acquiring HIV. So in this case, if you had a score greater than or equal to 10, your risk for acquiring HIV was about double that in the general population. So 2 per 100 person years rather than 1. And what was very interesting is that if you scored less than 10 on this scale, we saw no new infections amongst those people. So it was really helpful in terms of negative predictive value, in terms of trying to define those at higher risk versus those at low or no risk. And we incorporated this into the 2017 guidelines. So this is hopefully for people viewing this webinar, this is a familiar checklist. It's included as part of our HIV treatment guidelines, the PrEP-MSM score, and it's based on age, number of sexual partners, whether you had sex with or without a condom, whether you had receptive anal sex, whether you had male sex partners that you knew to be HIV positive, and as well as if you've used crystal meth in the last 6 months. So yeah, so we included the PrEP-MSM score in the treatment guidelines, and really have fairly good confidence that it's a good tool for distinguishing those who really could benefit from PrEP from those who probably wouldn't benefit from PrEP. And in this era, kind of 2012 to 2016, we found that awareness of PrEP amongst HIV negative men really increased over time. So we have people in the Momentum study coming in every 6 months and doing surveys. And we found that the awareness of PrEP is, at least have you heard of PrEP, and whether you knew much about it, awareness increased from just under 20% in 2012 to over 80% in 2016. And not surprisingly, the people who were more aware were more likely to be white, have higher income, be more educated, and identify as being gay as opposed to bisexual or other sexual orientations. But interestingly, also they were people that reported greater sexual sensation seeking, ecstasy use, viral load sorting, and multiple past STIs. So the aware group were actually people that were probably at higher risk for acquiring HIV. But even though 70% of people reported medical insurance, by the end of the study in 2016, only 2% reported ever using PrEP at any time. So awareness had increased, but uptake really hadn't increased at this time. So then, as Janine will describe in more detail in a moment, we were blessed with a publicly funded PrEP program in 2018. And this sort of prompted us to revise our guidelines in 2019. We were very happy that we could remove that caveat about our recommendations for PrEP and say, yeah, PrEP is now publicly funded for people meeting clinical criteria. We did add a little bit of clarification on the role of on-demand PrEP. In BC, the EPRGAY trial showed it, which again showed 86% efficacy. That was a trial where they were recommending not people take it every day, but taking it the day before and 2 days after having sex without a condom. And that seems to work just as well for people that are able to adhere to that schedule. And then there was also some clarification about what to do in the event of demonstrated nephrotoxicity or challenges with kidney function. And Janine will talk a little bit more about that, about the options that we have today, but that's the link to our current guidelines, which are still active right now. Okay, so I'll pass it over to Janine to talk about implementation of the program.
So thanks, David. So I guess I'll talk more about the program level. So so this is a bit more of a, I guess, just an overview of some of the timeline. So David talked a lot about the pivotal clinical trials and also kind of the different agents, like basically with emtricitabine, tenofovir, DF, which was previously used for treatment and then repurposed for this prevention kind of approach. And really, I guess, moving closer to kind of like the actual January 2018 date is that really it was this particular emtricitabine, tenofovir, DF actually getting Health Canada indication in February 2016 for PrEP, but it actually becoming available as a generic formulation in the summer of 2017. That actually maybe made it more possible to actually kind of maybe implement on a broader basis across the province. So that led to our Minister of Health, and I think it was like New Year's Day or something like that, January 18, announcing that we would be able to expand coverage of HIV prevention medications. And it was actually both post-exposure prophylaxis and pre-exposure prophylaxis, expanding the accessibility. So for post-exposure prophylaxis, it was for those who were at risk after having an exposure and getting medications afterwards, for those who were in for both non-occupational and occupational, and then also pre-exposure prophylaxis as well. So just for those, I think probably most of the audience is probably aware, but I think we're very fortunate in BC. We have a very integrated kind of system and process, and really PrEP was kind of like following very, very much kind of this integrated process. We have like a wonderful committee of multidisciplinary committee kind of informing guidelines and also scientific review of new drug therapies, and that leading into kind of a centralized negotiation of medications, distribution, procurement, and everything. So what happens is, yeah, what we think is actually it flows fairly seamlessly, and it's 100% publicly funded. So it's a little bit outside. It's a provincial program funded by the Ministry of Health, but there's no copays to HIV treatment or prevention in BC. And there's also, that becomes, it is centrally distributed, and I'm going to give kudos to our pharmacy who does great work with getting medications out there, and also having expertise in counseling clients and being able to do kind of like quick, even like clinical checks, like is it appropriate to, it's basically appropriate use of the drugs. They're clinically eligible, it's safe for them to use. And there's kind of like checks that happen ongoing there from this, the central standpoint. We also involved in monitoring and evaluation, kind of outcomes in the program, and also kudos to the education group too for also doing like promoting, basically educating providers. So we're lucky in BC because it's a different model. We actually allow any provider to prescribe, any physician to prescribe PrEP or ARV treatment. And so really it's basically very accessible educational modules from the education group, and also kudos to them for expanding that to nurse practitioners. They have this great nurse practitioner program to also expand kind of prescribing and educating nurse practitioners in BC for both prevention and treatment. Okay, so won't go into too much detail, but just based on, this is the front cover of the latest PrEP guidelines, and really the enrollment is really tied in very much into kind of what the recommendations are with regards to who is eligible. So really there are certain clinical criteria which would identify individuals who are at elevated risk for HIV acquisition. So once again, stemming a lot from what David has already reviewed, and that's men who have sex or trans women who have a PrEP-MSM score of 10 or greater, having infectious syphilis or rectal bacterial sexually transmitted infection, having a known HIV positive partner where you're not certain that the person is suppressed, and also those who've had basically non-occupational post-exposure prophylaxis on multiple occasions in the past, all predictive of elevated risk of HIV in acquisition. And there's also some recommendations too with regards to persons who inject drugs, and also heterosexual. Here it's because of the data is not quite as strong there, is that also the recommendation here, it has some clarity. But on the bottom right, we just want to make sure the audience is aware is that there are, beyond the guidelines too, there are individuals who providers think there's a unique risk or elevated risk that isn't necessarily covered in the guidance. And so we have a lot, quite a few applications that come in through clinically assessed risk. And there's also on the bottom, there's some safety, renal safety and hepatitis B co-infection status, which is very important, or infection status, which is very important to know before you implement tenofovir and FTC. So the application form is just depicted here, and bottom line is it's just, we try to do is simply incorporate just the really necessary bits that are needed for any provider to be able to kind of put the application in. So on this application form acts as both a check for clinical risk, safety, and also acts as the initial prescription. And this is really kind of integrated into our system on the right here of dispensing through our central pharmacy, and this ability to actually, for this information, whether it comes to dispensing, risk information, and some other safety information or discontinuation information and reasons for that, it actually all becomes available to us to kind of assess what the whole program. So I wanted to bring to your attention too is that monitoring and evaluation is a very important part of, this program was, it was thought very much of at the very beginning that it was very important to kind of understand not just kind of like performance indicators like how many people are enrolling in the program and where they were geographically, but information about risk, and also about maybe some of the unintended consequences of PrEP. So some of the things that you'd be worried about is maybe syphilis diagnosis. Also, are people getting tested? Are they appropriately getting safety testing? And also adverse drug reactions to actual medications that we're actually providing as well. And so Viviane Lima led the development of this indicators report with the technical monitoring committee, which has representation of all health authorities. So this is just to give you a quick overview of the overall enrollment in the PrEP program over the 5 years. And so it has, maybe it's tiny here. So in green is well, we will go through blue. The blue has the overall cumulative enrollment, and really we have about 11,000 individuals who have ever accessed PrEP through our program. And so which is quite remarkable in that short period of time. Just to give you some perspective, as I think we have about 400 people in our drug treatment program right now. And maybe, I don't know what it's, maybe 20,000 who've accessed it ever. So really, it's really kind of grown quite quickly. And really also in green, we have our active participation, and we consider people who PrEP is a little bit different, or challenging to understand who is actually active, because people can be on an intermittent, use it on an intermittent basis. But based on our definition of having used it in the past 6 months, is that you can see that we have active participation of over 6,000 clients as well. And some demographic information on the side. It's a younger cohort. The median age is 36 years, primarily cis male, and primarily living in Vancouver Coastal or Fraser Health Authority, kind of very like to the population. And also with regards to who are applying for this and how are they eligible for these are the main criteria. So basic, I think it's like well over 80% are eligible based on HERE risk, HERE-MSM of 10 or greater, and sometimes also reporting a second risk factor like an STI or having an HIV positive sexual partner. So I guess sometimes what we want to know is how are we faring compared to the rest of Canada? Like it was just, we were so focused on BC, and so this is a PHAC infographic that was made available in December, and I think we also contributed to this. It's trends in PrEP use in 9 Canadian provinces, and you can see that overall, in general, overall, this PrEP use in Canada has increased, and it's overall also highest, very similar to us, highest use in men, 98% in that age category of 30 to 39 years. And if you look kind of closer to British Columbia, we're very proud to say that the BC has the highest uptake in Canada. And not to imply too much, but there are different systems and different coverages of PrEP by province or territory. And that's just on the bottom right there is universal coverage, means that if you're eligible based on whatever criteria, that it's 100% covered. And where some other territories or provinces, perhaps it's like a co-pay system, or they look at private insurance, a little bit more complicated. We also looked at, I guess, at just to like it's that you saw from the overall uptake, we saw that we were overall increasing uptake, but there were some, of course, during this time of PrEP implementation and ongoing kind of operation, is that we experienced the COVID-19 pandemic. And really, and what we wanted to understand, and maybe we're still trying to understand, is what that impact has. So we did look more closely at, and there was definitely impacts pre and post pandemic. This is looking at basically whether it's new PrEP initiations, clients with PrEP dispensed, or clients with HIV testing, is that there were definite impacts due to the COVID impact, like, and we looked at 15 months before and 15 months after, and there at the end of that period of time, there was a recovery, but not quite back to baseline. And I know that this is, we have work colleagues like Jeff Joy and his group have done some work looking too, is what are the impacts on new infections, and they've seen some maybe new infections due to kind of in certain clusters of the population. So I'm going to give this back to David. This is impact of publicly funded HIV PrEP in BC.
Okay, so this is data that comes from the BC Centre for Disease Control, and I've just kind of added in the last 3 years here because they haven't sort of given us an updated slide like this for a while, which I always find really helpful. So as you can kind of see, the orange line is sort of the total number of new diagnoses in British Columbia each year, beginning back in 2011. And you can kind of see that there was kind of a steady, slow decline in the number of new diagnoses up to really until 2016. We actually saw a big drop in 2017, the year before we actually started publicly funded PrEP, which is hard, and which is hard to know, what caused that. We know that, when diagnoses do not, completely equate with incidence, because people can have can be infected with HIV for a number of years before they actually get diagnosed. But anyway, we did see this drop in 2017, but we've really seen a steady drop in new diagnoses really since the start of the PrEP program, particularly amongst men who have sex with men, which is really, you know, the group that is predominantly benefiting from the PrEP program, and such that we're seeing, you know, the lowest number of new infections in British Columbia since really the epidemic started in the mid to late 80s. We don't have the data broken down by exposure category for 2021, but the number of diagnoses it was up a little bit. I think 147 as opposed to 137 in 2021, but still well below sort of historical norms for this, and really, you know, men who have sex with men have really benefited from this program. When we look at, so this is actually incidence data, or sorry, uptake data from the ENGAGE study, which was a similar study to Momentum 1, except that we've now done it in Toronto and Montreal as well. So this study started in February 2017, took about 2 years to enroll people, and we're still following people today. And if you look at, you know, the first people we enrolled in the study in 2017, 2018, you can see that there really wasn't much of a difference between the 3 cities as far as who had ever taken PrEP in the 3 cities. But you can see that after 2018, not immediately, not in the first 6 months, but afterwards we see a pretty steady increase in PrEP uptake amongst Vancouver participants in the orange line. And really, you know, we do see some increases in Toronto and Montreal, but not to the same extent as we have in Vancouver. And if you looked at, if you asked sort of participants in Vancouver if they were aware of PrEP, you know, the odds of them being aware of PrEP was almost twice as high as the other 2 cities, and similarly for PrEP use. So we're able to actually kind of monitor the impact of the different ways that PrEP is funded and promoted in the 3 provinces through this study. And as Janine mentioned, you know, Quebec and Ontario do not have fully funded PrEP programs at no cost to their participants, and coupled with that, they don't have the same kind of promotion and educational activities that we're fortunate to have here in BC. And then if you look at the outcome of HIV incidence in the 3 studies, it does appear, or the 3 cities in the ENGAGE study, it does appear that Vancouver had a lower HIV incidence rate than the other 2 cities. Although the confidence intervals here overlap, so they're not really statistically, the differences are not statistically significant. But the other thing to know is that we actually have, you know, really complete data capture in British Columbia compared to the other 2 provinces, because we consent participants, we ask people for their consent to link their data to the HIV drug treatment program. So even if they don't follow up within the study, but they do show up and get a viral load later through their care providers, we'll actually be able to identify them as a new infection. So we're kind of biased to having a higher incidence rates in Vancouver, but even with that, it seems the trend is towards a lower rate. And then that incidence rate of 0.3 per 100 person years, that's about 70% lower than the incidence rate that we measured in Momentum 1 in Vancouver. Again, suggesting that, you know, the PrEP program has probably had a big impact. Although, you know, we have seen, you know, slight improvements in the proportion of guys living with HIV who have virologic suppression, but that was already quite good even back in 2012. So really, you know, we do think that most of this is really related to PrEP.
This is, there was some, David presented some data on new infections in BC, and this is looking in particular at the cohort itself, I guess the cohort itself, and this is just preliminary data through June of 2022, including everybody who had actually, I think, been dispensed PrEP at least once, and it didn't include people who were maybe on or off drug at the time of going, but we wanted to calculate what is the new HIV diagnosis rate and the thing, and it's, you can see here, this preliminary, it's 0.13 per 100 person years, which is very low. It's very low, and this is over 20,000 person years of follow-up. And you can see how that compares to kind of what you've seen kind of even in clinical trials as well, but this reflecting kind of our participants. And there, of the number, and there were, I mean, obviously every new case, it's still a sad kind of story. So we're also trying to understand a little bit more about what, like, who are these failures? But we're finding too is that these aren't, for the most part, they're not biomedical failures. Like, it's not because it's really has to do with not being on the medication or the intervention itself. It's not necessarily that you were on PrEP and that it failed, that you were not on PrEP at the time you were diagnosed. And I guess on one hand, we're also reassured that for any of the new diagnoses to this point in time is that there weren't any cases of PrEP-related tenofovir resistance observed in those new diagnoses. And of course, we're continuing to monitor this and always recalculating what these, and also trying to understand a little bit more about those new about the new diagnoses and ways to support them, or what we could have maybe done a little bit differently. I won't go into too much more on this one. This is actually very similar to what David had shown, and we did a calculation. This is the once again, these are the CDC data with regards to new infections in BC, and showing this is the 24 months before and the 24 months after PrEP rollout. And we just did a calculation on what is that. What now, of course, many will say, of course, PrEP is only one intervention. Obviously, we have many things going on at the same time. There's really with regards to education and also treatment as prevention. So I think that really, but what was observed was a 31% risk, relative risk reduction in HIV diagnosis amongst MSM, and there wasn't, like I said, without in the other groups, there was not really an increase or decrease, but really no change in other populations of interest. So my last two slides, I guess, before discussion is that I'm going to go over a little bit about PrEP safety monitoring, and I just wanted to acknowledge Kathy Lepek for providing me with this slide and some of this data. So she was basically, so part of the monitoring of in the PrEP program is safety, and drug safety monitoring has been done since the program has started. So I think there's we wanted to understand, you know, like putting people on for a prevention medication, you're thinking, okay, or is there excess risk to taking this? So I guess there's a little bit data. This is from the 2021 PrEP, the Pharmacovigilance annual report, and it does cover both the treatment program and the prevention program. So that's actually quite nice, because then you have these nice comparisons here too. So on the top left, there is you have ADR reporting rates for HIV treatment in blue and prophylaxis in orange. So it's just in general. And you can see that just in general, there's a lower rate of ADR reporting in PrEP period versus antiretroviral therapy. And for ADR rates in PrEP remain low and stable and since the inception of the program. So if you want to look more specifically at tenofovir DF, which is basically main half or whatever component of PrEP, for our program, is you look to the right there on B, and you can see there that this is annual ADR rates looking at tenofovir DF for treatment in blue, and for PrEP in yellow, and you can see that the rate is several-fold higher for treatment. So perhaps this is not a surprise for people like the treatment program. People are, it's an older cohort with likely more comorbidities, and I feel like, and so this is maybe not necessarily a surprise, but it's also very reassuring that that overall safety of using emtricitabine and tenofovir DF is safe. And on the bottom figure, there's just a breakdown of what is most commonly reported symptoms associated with TDF for HIV treatment in blue and PrEP in orange. And you can see the orange is very tiny, but anyways, there's been some cases reported of renal and GI, and maybe some non-specific CNS things like dizziness and headache, I think, but overall quite low. But I think maybe what we want to ensure to, or just want to make sure the audience knows that this, although tenofovir DF and emtricitabine is kind of like first line for PrEP in BC, is that if you do have an individual who's experienced an adverse drug reaction, then we do have an alternative. It's non-formulary currently right now, but Disco FTC TAF, or like a emtricitabine tenofovir AF, which is brand name Descovy, is an alternative. But I think what I won't spend too much time on, because it is still non-formulary, but what I want to make sure that people are understanding that if you have a client who has persistent EGFR less than 60 or a diagnosis of osteoporosis is that you can submit for exceptional approval for something like Descovy, but you must also be aware is that it hasn't necessarily been evaluated in all populations. So it's really only, should not be used in heterosexual men and women, trans males. It shouldn't be used also in, and it should also not be used for on-demand use as well. And it is, and it's currently also for non-formulary, and it's also not available as a generic quite yet. But just wanted to make sure that individuals knew that there was an alternative for people who are experiencing adverse drug reaction. And so, oh, that's the end of the slide. This is just my mega list of acknowledgements to, in particular to the participants of PrEP and all the clinicians and who are involved, and all a gazillion other people in the BC-CfE and beyond that I've listed here. And I'm gonna.
These are just all the logos of the organizations involved in the Momentum and Engage studies. Yeah, that have contributed to this. Obviously, lots of people that helped to make this work happen. And thanks very much.
Thank you.
Thanks again for your patience, everyone. And I'm just going to start with a few of the questions from the audience, and then we will see how much time we have. I think some of them are really just questions for clarification. First, to Dr. Toy, there's just a quick question here about eligibility for PrEP. And I think the way it came across in the presentation is that for MSM, infectious syphilis or rectal STIs were a requirement for consideration of PrEP, but I think that really just requires a little bit of clarification.
Yeah, so I mean, others can clarify. No, so that was, it's one potential, one of any, yeah. So any one of the criteria there, it really doesn't have to be in combination with any, would qualify one to receive PrEP. And
so any STI really, and any of the other
yes, many,
yeah.
I guess from perspective of what you could do kind of in the office is that most of our qualifications come based on Harry score using the questionnaire, but some people absolutely they qualify merely based on having having an STI or infectious.
But it is actually rectal STIs because those are really an indication
of higher risk. Yeah.
Oh, sorry,
okay. And then again, I think this is better for you, Dr. Toy. Where can patients get their medications if they cannot come to St. Paul's to pick them up? So are there other dispensing sites? Can you just talk a little bit more about how the program does get meds to patients? Yeah,
so this is for the centralized program, I guess I can just summarize for, so it's very similar to the HIV drug treatment program. St. Paul's Hospital is the main hub pharmacy for distribution of antiretroviral medications, both HIV treatment and prevention. If one lives outside of, there are several satellite pharmacies in BC in other centers like Nanaimo, Kelowna, Victoria, that also carry medication. For the PrEP in particular is that, so clients can either come to St. Paul's to pick it up. They could, it could be sent to one of the satellite pharmacies or can be picked up at one of the satellite pharmacies. Also, if you live outside Vancouver, then it could be sent to any healthcare provider or an agreeable pharmacy. But it does come, the main medication does come from St. Paul. So there's a little bit of coordination that does happen once that's established. It's fairly smooth, but I feel like this way that really people, even in rural or remote areas, can actually get their medications, even in the smallest town, because I think not all pharmacies, it's true, even if there was, these medications are not necessarily ones that pharmacies would choose to carry as well, and sometimes, so it's actually nice that the pharmacy here always has supply and being able to pivot. So that's, and that's the general system.
Okay. Okay, thank you. A few more questions here. Now you commented on the need for safety monitoring. Has there been any thought to sort of lengthening that time in between testing and safety monitoring when people are on PrEP? And maybe you can just comment on the importance of that, as well as the importance of monitoring for acquisition of HIV and a bit more about that.
Yes, I know, and maybe David too also has a comment too. And I think that there is, our recommendation in BC is to have monitoring, whether it's actually HIV testing and something we piggyback on renal monitoring and also STI testing. Our recommendation is for those actually, the STI testing and HIV monitoring, I think it's every 3 months. I think for the actual serum creatinine, if you have a normal, healthy, regular person with a normal serum creatinine, is that, actually I can't remember in your guidelines, David, if it's every 6 or.
Well, I think it's written as every
3
months.
Yeah.
But yeah, if you've got, I would think if you've got, several months of being on PrEP and show that you have a normal creatinine, the incidence of renal problems after that is extremely low. So you probably don't need, I mean, I think the guidelines say every 3 months, but I think you probably don't need to do it that frequently. But it is important to mention that, like, checking for HIV infection is an important safety consideration too, right? Because you don't want to be, if you do develop HIV on PrEP, which is extremely rare, you don't want to be treating it with just the two drugs, right?
Okay, great. Another question here just about where data comes from. So this particular question is, what data source is used so that we can know the number of patients on PrEP? Is it based on pharmacy data, for example, or is it based on drug treatment program?
Yeah, I guess that's maybe they're part and parcel. Yeah, because I think really it mainly comes from the clients enrolling in the program, and really it's linked to application for medication. So it really comes from, for the most part, from enrollment into the program and the form that maybe is submitted, and then there's also some laboratory data, laboratory data that we also receive to support that as well.
And you do have your the PrEP monitoring reports. They're available on the website, right?
Yes, yeah. So these
want to look up and see.
Exactly, yeah. For both drug treatment program and the PrEP program, this information is available to the public as well. So if you go, it's maybe a little bit harder to navigate, but if you go to the BC-CfE website and go to the drug treatment program, and there should be like a thing about there's reports or communications, and you can find the reports there.
Fantastic. Yeah. Okay. Quick question here about if local pharmacies do agree to act as distribution points for PrEP, are they compensated in some way? And I have no idea.
Yeah, so I mean, because this St. Paul's Pharmacy is the dispensing pharmacy, so really they are taking responsibility for basically whether it's that screening, that safety check, like the renal monitoring, is it appropriate to restart if a client is restarting, and also taking on the responsibility for counseling the client, whether that be on the phone or in person. So actually, so because that responsibility falls in the St. Paul's Pharmacy, is typically a site that is picking there to receive medication, is used kind of as a depot. So really the work and the compensation is basically covered under the St. Paul's kind of service as well. I mean, there are situations too where we do have pharmacies who do provide like extra support sometimes, and those are sometimes situations where there's maybe a unique scenario. Yeah.
Okay. I'm gonna just move on to a few sort of reflecting moments if we can, but I'm happy to take more questions from people listening if they want to type them into the chat box still, or the question box. But I think we all remember when PrEP was not publicly funded, and how challenging that was at the time, and really what an amazing change it was when the BC government graciously agreed to fund PrEP. But I don't know if either of you remember or know much about how that negotiating went and how, like, what happened. Was there a fair amount of convincing that needed to happen? I sort of remember, I vaguely remember presentations that you had to give, Dr. Toy, to show some effectiveness of PrEP, and I do remember that.
Okay.
I do remember that, yeah.
Anyways, I was telling David that my tenure at the CFE started, I think it was the fall of 2017. So this was actually my first job, was actually the implementation of PrEP. And so actually I can't claim credit to actually any of the negotiations with, but I am aware that I guess with regards to being able to kind of expand access to it, there were a few things. Obviously, people had done a lot of the heavy lifting. I think leadership did. We're fortunate enough, I think, because HIV treatment and prevention is under one umbrella. So really, when it comes to actually, let's say, when it comes to getting affordable drugs or whatever access is, that you can do it kind of as a whole. And then I think there was a lot of effort to make sure that there was an affordable, sustainable access to treatment, something that not just to start, but something that you could sustain. And that also was made possible because of we had there was the availability of generics and our ability to, like I said, maybe without necessarily, I think maybe I don't know if this is saying too much, is that we're able to maybe advocate for it without actually having to ask for additional money from the province, and basically saying if we could do this and fit it under our kind of existing budget, whether it means like, so to implement it, and then I think that's really kind of what led to the actual successful implementation.
Yeah, I think you're right to comment on it was such a powerful move from leadership to even create that environment where it was something that we could do.
Yeah. And I think, and obviously there was everything else was supportive, a lot of David's like work and momentum, and also the clinical trial data and everything, but it was kind of all there.
Yeah. Now we're seeing lots of other provinces adopt PrEP, as you were showing us in your presentations. Are they reaching out to you and asking for advice or guidance? I mean, you quite rightly said that we were one of the first provinces in Canada to do this and have a lot more experience. Have other people reached out to you to ask for advice?
I don't know if anybody's reached out to David. I wouldn't say necessarily specifically to PrEP, but actually got how the BC system works with regards to kind of the whole integrated aspect of it. We have had questions from some other provinces with regards to, for example, developing maybe similar registry or central kind of system as BC, and also with regards to kind of maybe specific aspects, like whether it's, and also with regards to maybe even for your groups, right, reaching out for education. With regards to PrEP, I think a lot of it has to do with that we're able to do this because we have this centralized distribution and 100% covered. So I think that really some of the barriers are the varying systems too.
And the other thing, I wouldn't say that we were actually the first province to have PrEP, because Quebec has a comprehensive pharmacare program that pays for kind of more or less all prescription drugs. But the difference, and so as soon as PrEP became, or tenofovir and emtricitabine became licensed for pre-exposure prophylaxis, it was on the Quebec formulary. The challenge is that there's a pretty significant copay that if you're not on welfare or disability, you have to pay. I think it's about $80 a month or something like that. And while for a lot of things that's a small proportion of their drug costs, it can be quite a barrier.
Now we only have a couple minutes left. I think we have time just for this one last question, which is interesting. Whether there's been any work done looking at where people are accessing PrEP across BC. Like really, I seem to remember you doing some work around this and how much of it is centralized around Vancouver, like what kind of things we could do to improve equity of access around the province, things like that.
Yeah. No, I think we do, and these are, I think also if you even look at the PrEP report, which I think might also help you characterize it, maybe it's higher level with regards to health authorities, but yes, it's definitely centralized in the lower mainland access to PrEP. We do have some stats with regards to where people, their residence, their place of residence, and maybe also their place where their provider is too. So you can see this very interesting sometimes is that people sometimes cross over those, maybe they're just borders with regards to maybe access healthcare as well. But yes, certainly there's, but it's true. It's like we want to ensure that that regardless of where you live in the province, is that you potentially can get this treatment. And so really, that's why I guess even probably more so in the treatment program, but there is quite a bit of like, let's say putting the medications back out. There's maybe, I think it's maybe about 20% or a bit more like that for the PrEP program where it's actually sent outwards. Yeah.
Well, with that, I'm afraid that we're going to have to draw our discussion to a close. Really, I'd like to thank Drs. Moore, Dr. Troy. Thank you so much for being here and for sharing your experience with BC's PrEP program and your expertise. If there's additional comments, please, as I said earlier, please email them to us at education@bc-cfe.ca. In the chat box, you'll see a link to our questionnaire to give us feedback. And once again, thank you for attending, and we look forward to you joining us for the next chapter of our conversation series. So thanks, and have a lovely afternoon.